Chapter 18, Gastrointestinal and Genitourinary Emergencies. So first things first, like every other chapter, we're going to talk structure and function. So if we take a look at our pictures here, on the left side, we have the upper quadrants of our abdomen formed by drawing a line through the umbilicus along the midline and drawing a line splitting the body into inferior and superior right through the umbilicus. And that will give us our left and right upper quadrants, our left and right lower quadrants. Now, if we take a look at all of those structures in the upper quadrants, what's something, knowing just a little bit of anatomy, that you guys can tell me about what's in those upper quadrants?
The
What
upper quadrants of the GI tract, correct?
upper quadrants of the abdomen? We're going to talk abdominal structure here for just a couple minutes.
So you're looking at like the liver, the pancreas, the kidneys.
And those are all solid organs.
Right.
Solid organs have a lot of blood. They are very vascular. They are repositories a lot of times for blood, and they are very susceptible to causing internal hemorrhage. If we look down at the lower quadrants now, we're gonna move over to the right side of the picture here. Now, arguably, yes, there are hollow organs up in the upper quadrants as well, but in the lower quadrants, what do we have more of there, hollow or solid?
Hollow.
Hollow, and all of those hollow organs are more susceptible to rupture and spilling their contents into the abdominal cavity. Now, just like with the lungs and those visceral and parietal pleuras, we have visceral and parietal pleura in the abdominal cavity as well. It's called the peritoneum. The visceral is the internal lining that touches against the organs. The parietal is the pleural lining that lines against the abdominal wall. And really much the same function, much the same reasoning behind the pleura in the lungs. It's to keep those abdominal organs separate and contained and keep them sort of being able to do their job without having too much stress or increase in friction, increase in rubbing, and really just to keep things contained. What we're going to talk about when we talk about visceral and parietal in a couple of slides is the way the problems of visceral pain and parietal pain will present, the different pain that we will see with hollow and solid organs, respectively, and really how difficult it is to figure out abdominal pain in the field. Because all of these bits and pieces being stacked so close together and being really on top of one another makes it very, very difficult to come up with a real working field diagnosis. What we're looking at most of the time with abdominal pain is really just what we call the acute abdomen. Sure, we can sort of dial in the pain to figure out what type of organ might be causing the patient their problem, maybe what has happened to the patient depending on nature of illness, mechanism of injury. But really, abdominal pain is abdominal pain until they get some images and get some lab work and figure out just what the wheres and what fors are. We do have to know some bit of anatomy and physiology as to where these organs lie. When we do separate the body into the right upper, left upper, right lower, left lower, when we're palpating over those things, it is good for us to know what exactly lives in that quadrant. It's imperative to know for things like appendicitis, that if I'm touching the left upper quadrant, well, that's probably not an appendicitis. When we are talking about something like cholecystitis or gallbladder inflammation, it's really important to realize that if I'm pushing on the right upper quadrant, and my patient complains of some referred pain, don't worry, we'll get into where it refers to shortly. That could mean my patient's having a gallbladder attack. So knowing that the liver is in the right upper quadrant, going across actually the anterior of the upper abdominal cavity into the left upper quadrant as well, is an important distinction to be able to make. Knowing just where some of these structures are and what is most likely underneath and injured is pretty much where we earn our keep as far as assessing the acute abdomen goes. So we'll get back to it again. We have hollow organs, solid organs, and many, many vascular structures inside the abdominal cavity. Those hollow organs, their job is to keep things inside. Hollow organs really don't have the same amount of blood supply as the solid organs do. They tend not to bleed as much as solid organs do. But let's take a look at those hollow organs again on the right side of this picture. And what's the kind of stuff that those hollow organs house? Like, what do they keep inside of them?
Waste.
Yeah, waste products. So those waste products are in those organs as a result of trying to be moved out of the body. So having those waste products just free floating in the abdomen is going to be problematic, not just for an irritation, inflammation, pain standpoint, but all of those waste products just leaching into the cells and leaching into the tissues and aggravating the structures all around also will create systemic type infection, maybe even sepsis type problems that we may see sort of downstream, even well after the organ itself has become damaged. For the most part, our solid organs, we think rupture and we think bleeding, not leaking of contents and not really that inflammation, irritation, infection type. This is someone who may, without ever spilling a drop of blood on the ground, really be in some profound hypovolemic shock. And then running through right up the midline, through the abdominal cavity, up into the thoracic cavity, we have all of the important vasculature. We have the abdominal aorta, we have the inferior vena cava, we have real significant blood vessels that are responsible for either A, getting blood out to the body from the aorta, or B, getting blood back to the heart with the vena cava. And a problem with either one of those is going to be a pretty significant problem for our patient, up to and including their demise. So let's talk abdominal pain here for a minute. Here's the pathophys of abdominal pain. We have mechanical issues, inflammation, or ischemia. That ischemia should look very, very familiar, and we'll talk about that. Mechanical forces, meaning things like stretching or when outside forces are applied. Even something including like a bowel obstruction can be somewhat of a mechanical force leading to rupture of the intestines. When a blockage gets there and that intestine behind it starts to swell because more food and more waste and more excrement is beginning to pile up, sooner rather than later, that tissue is not going to stretch any further. And when it does, our patient winds up significantly ill pretty quickly. Next, we have inflammation. Well, that's just what it sounds like for any of the other inflammatory things that we've talked about. The tissues being irritated, the tissues being aggravated, could be as a result of one of the organs near it being damaged, or it could be as a result of the organ itself having sustained some sort of problem. And that inflammatory process is part of the immune response, but it's also quite painful. And then last but not least, we have ischemia. Your GI tract is surrounded by a very, very large network of vasculature. The mesentery veins and mesentery arteries really just wrap your GI system in a network of capillary beds, because all of the food that we take in, all of the nutrients, all of the energy that's going to be created starts in our GI system. Our stomach begins the digestive process. We get into our intestines. Things get to the small intestine and get into those capillary beds in order for those capillaries to transport around all of those nutrients. If parts of our GI system become ischemic, that means they are becoming hypoxic because they are having a problem with oxygen delivery and carbon dioxide removal. So that ischemia will start to cause some infarction, just like with a stroke, just like with a heart attack. It's just in the abdominal organ. And the ischemia is going to make it so that the cells of that organ no longer function once they have gotten to a point where ischemia turns to infarct. And we'll see a patient who probably needs some pretty significant work under the hood, having, bowel resection and possibly even bypasses and things of that nature, just because they need to either A, get the bad piece out, or B, restore some oxygenated blood flow to hopefully reverse that ischemia. So I told you visceral and parietal would rear their ugly heads yet again, and here they are. These are our types of abdominal pain. When we talk about visceral pain, it is generally when the organ itself is involved. So these are going to be more of our solid organs. The pain is usually a little less severe, difficult to localize, sort of dull, aching, just a constant bother. Visceral pain is a lot of times associated with nausea and maybe some vomiting. On the other side of that, we have our parietal pain. Parietal pain also sometimes is referred to as somatic. It is inflammation of the peritoneal lining. So it is irritation of that cavity lining in the abdominal cavity. Generally, it's either localized one side to the next. It's generally very, very sharp and typically constant. So if visceral pain is damage to an organ itself, and a lot of the times we think solid organ with that, parietal pain generally being irritation and inflammation. What do you think the root cause of that is a lot of times referred to? If we had all that bacteria leaching out of a ruptured hollow organ, filling up that peritoneal cavity, does that sound like it would cause some inflammation, some irritation?
Sepsis.
Yeah, so that parietal pain, a lot of times we think of things like rupture of some sort of hollow organ. And then last we have referred pain. Referred pain typically is visceral in nature, but it's also felt elsewhere in the body. It's difficult to localize sometimes, but if I were to push on my patient's right upper quadrant, that pain would refer to the same spot all the time. It wouldn't be I'd push on the right upper quadrant and it would be referred to their chest one time, and push on their right upper quadrant and be referred to their shoulder the next time. Generally, that referred pain is going to just continue to travel along the same neural pathway to deliver the same pain just about everywhere. So if we're talking peritoneal cavity, what do you think peritonitis means? Somebody break the word down for me. What does itis mean?
And itis is infection? I'm not sure.
Not necessarily straight infection. It normally means irritation, because it can have many, many causes, infection being one of them. So Malachi, since you jumped up and gave me a bit of the word, what do you think the periton, what do you think the suffix and root of that word stand for?
Surface? I don't know.
So think even easier, right? We're talking about the abdominal cavity. the peritoneum.
Right.
Peritonitis is inflammation of the peritoneum.
Right.
It can be caused by blood, pus, bacteria, chemical substances, anything that irritates the peritoneal cavity. Signs and symptoms, we're going to talk abdominal pain all morning. So peritonitis can be abdominal pain or tenderness, nausea, vomiting, diarrhea, anorexia. Anorexia in medical terms means just not wanting to eat, not being able to eat. That Markle test on the bottom, we're going to have the patient stand on their toes and then drop their heels down with enough force to hear an audible thump. That can give us a positive Markle test because it will send a shock wave through their abdomen and it will, it will produce some pain. But most of the time, our patient with some pretty significant abdominal pain is going to be most comfortable, much the way that this patient here is laying. So palpating the abdomen, really in practical terms, is going to be our best bet. We're going to systematically examine the abdomen. We expose the patient's 4 quadrants and we work by palpation, small little clockwise movements. We want to start as far away from the painful quadrant of our patient's abdomen as we can, because the minute we touch that painful spot, it's going to be painful everywhere. So inspect, palpate. We don't really have to auscultate. I'm not going to expect you guys to take bowel sounds. I know what bowel sounds sound like. I couldn't tell you regular versus irregular, slow versus fast. I don't have that much experience, and I don't imagine you guys will gain that much of it either. But palpating the patient's abdomen is going to be something that we do. We're looking for pain, tenderness, rigidity, and distension. If we find any one of those things, I mean, even people that are in great shape, if you just sit there and palpate around in their abdomen a little bit, it's going to feel soft. It's not going to feel tender to them. It's not going to cause them any pain. It's not going to be distended, this big bloated belly. And we're not going to feel any rigidity. If you find one of those things, it is pathologic, it is clinically significant, and it does have a root cause somewhere. It could be you palpated right over the liver and found, a patient with a big distension there and some pain and tenderness and rigidity. But until some lab work is pulled and until some images are taken, guess what that is? Think easy here for a minute. Guess what we call that?
Just pain.
No, we're going to talk abdomen all day. So it is right upper quadrant pain,
All right.
positive for whatever they told you or whatever you found, pain, tenderness, rigidity, distension, whatever made it significant to you. Because there's really no way, we don't have our x-ray eyes with us. We left our x-ray glasses at home. So there's really no way for us to tell quite exactly what's going on under there. And inspection and palpation and patient complaint is really all we have to go on. So if peritonitis is inflammation and irritation in the entire peritoneal cavity, somebody tell me please, appendicitis.
It's the irritation or when food gets into that appendicite. You know what I mean?
I got you. So it's not really food. It is really, again, just inflammation, irritation. It really causes what we will call the acute abdomen. This is a real for life emergency. Appendicitis is very common in children and the elderly because their appendix wall actually will begin to be thinner in the elderly or is just anatomically thinner in children. And it makes it a little bit more prone to perforation. But what happens is we have that inflammation, we have that irritation and some swelling to the appendix. And if the wall is already thin to begin with, that thinning and that increased inflammation and that increased irritation can actually eventually lead to rupture. Common signs and symptoms for our appendicitis patient are going to be abdominal pain and some cramping in the right lower quadrant, low-grade fever up to a pretty significant fever if it's already ruptured and they are beginning to become infected. They're going to have a lack of appetite. They're going to have some abdominal guarding, so they are going to do everything they can humanly possible to keep you from poking that right lower quadrant. And really, the only definitive treatment for this is surgical. They try to get the appendix out before it ruptures so that way it doesn't cause the large-scale systemic infections we look for with an appendicitis patient. And our job is to get them to the emergency room, monitor their level of consciousness, airway, breathing, circulation. We are going to trend their vital signs. So we're going to reassess every 5 minutes, and we are just going to transport them to somewhere that can definitively solve this problem and get that appendix out of there. So appendicitis, peritonitis, pancreatitis. We have inflammation of the pancreas. Common causes for pancreatitis, what do you think? Remember, it's just inflammation. So what do you think some common causes of inflammation of our patient's pancreas might be?
Alcoholism is a cause of it.
Alcoholism is a cause of it. The pancreas, I know when we talked pancreas on Friday, it was mostly the endocrine function of the pancreas, the part of the pancreas that actually secretes insulin and keeps our blood sugar regulated. The pancreas also has a very important function as an exocrine organ and aids in digestion of food. So alcoholism is one, sure, but the exocrine part of the pancreas can be affected by gallstones. So gallbladder stones that will block off bile ducts and sort of limit the pancreas's ability to function as an exocrine organ. And really, one of the other big ones is infection. If a patient has some sort of infection that has set up shop in their pancreas, that's going to be another cause. Complications are pretty wide-ranging. If we're talking infection, we think abscesses or sepsis. The pancreas is a bit of a hollow organ, so we think hemorrhage, tissue death. Then we start thinking of some of the endocrine functions of it. So it could cause hypoglycemia, could cause the pancreas to just secrete tons and tons of insulin. Or it could be hyperglycemia, and it could interfere with the pancreas's ability to function and pump out insulin. So our blood sugar will go really, really high. And organ failure and really the end result to pancreatitis can in fact be death. Common signs and symptoms. Tell me if you guys are sensing a pattern here. Nausea and vomiting, abdominal pain, tenderness, and some distension. Could have some mild jaundice because of the inability of that bile to really get to where it's supposed to be. It builds up and starts to cause some yellow-looking skin. Could have some fever, rapid pulses, signs and symptoms of shock. But most of our abdominal patients are going to come with some nausea, vomiting, some sort of abdominal pain and tenderness, and some unwillingness to eat. Cholecystitis is what we're talking about when we talk about the gallbladder. Cholecystitis is inflammation of the gallbladder, is commonly caused by the presence of gallstones blocking those ducts, so the gallbladder gets big and engorged and can't do its thing. Generally occurs between the ages of 30 and 50, so not normally in kids. It is much more common in women. A lot of the times, the intervention for this is going to be surgical as well. The gallbladder is really not a super important organ when we talk digestion, so they will just take it out. Our signs and symptoms: sudden onset abdominal pain in the right upper quadrant. Normally it is associated with indigestion. Normally it is sort of right after a big heavy meal, high fat, and that pain, that right upper quadrant pain, will also be referred to the right scapula. Somebody tell me why that pain refers to that area. Think back to some of the neurology we talked.
Follows the nerve all the way up.
Yeah, that nerve that innervates the right upper quadrant starts in the spinal column. Starts as one of those spinal nerves that comes off the spinal cord and goes out to the business end. So it's going to follow that same neural pathway right back when I push on that right upper quadrant, and it's going to be referred to the right scapula. Signs and symptoms that go along with this: nausea and vomiting up to some sort of greenish in color looking mess, belching, heartburn, really just some GI upset. These are one of the ones that you will never forget: gastrointestinal bleeding. The stomach does not digest blood. The stomach just won't break it down. There's too much iron in it. The stomach doesn't know what to do with it, and it gets down there and it really irritates the stomach. So that is what we call an upper GI bleed. Blood that's actually leaking into the stomach and coming into contact with those gastrointestinal juices is going to lead to some upset stomach. It's going to lead to a patient vomiting something that looks a lot like the coffee grounds that you throw in the trash after you make a pot of coffee. And then we have what we will call a lower GI bleed. Now, a lower GI bleed can lead to black tarry stools, so the L in sample, last ins and outs. It can also lead to a significant amount of frank blood actually being passed when the patient has a bowel movement. One of the other things we will see with our patients who have a lower GI bleed and a lot of actual bleeding is it just has the most rugged, terrible, awful smell. You can legitimately follow your nose to your patient. Some of our causes of this can be peptic ulcers, can be gastric erosion from constant and continuous GERD. We could have varices in the organs themselves. Diverticulosis is a lot of times a significant cause of a lower GI bleed. GI bleeds are normally found in people between the ages of 40 and 70. And we can see all of those outward signs that we just talked about: the hematocyst, the throwing up of blood, the hematochezia, which is, I believe, I'm reaching back into my medical terminology. I'll probably have to look this up to make sure, but I believe that is that coffee grounds we were talking about. And then melena should be the actual passing of blood in the stool. But think of what's going on. Think of the root cause: bleeding. So what are some other things that we might see?
Hypoxia.
Hypoxia, yeah. So we'll start to see some signs and symptoms of shock. Maybe an altered mental status, patient complaining of some sort of just general weakness, some syncope, a patient who stands up too fast and gets lightheaded. But we could see pale, cool, diaphoretic skin. We could see increased heart rate, increased respiratory rate, maybe normal blood pressure. Maybe they've been bleeding for long enough that their blood pressure is sort of low. and we have a really rapid heart rate and a really rapid respiratory rate. So be on the lookout, because this patient does have a bleed, and it is categorically impossible to quantify how much, because you don't know, is it leaking inside only? Is it leaking inside and outside? What's going on? Difficult to determine. This is a nasty little bit of business right here. Esophageal varices, they are bulging and weakening of the blood vessels that line the esophagus. This is generally heavy drinkers who abuse alcohol like it's a mission. It normally goes hand in hand with some pretty significant liver disease. It is increased pressure on the venous side now. So that vasculature that doesn't generally have a whole lot of pressure built up in it begins to have a pressure now exerted on the walls of those veins. Common signs of a esophageal varice causing your patient a problem is going to be just large volumes of bright red blood just pouring out of this patient. You won't have any abdominal pain. What we're going to see are some pretty profound signs and symptoms of shock and an airway that is very much compromised, because there's going to be so much blood pouring into this patient's esophagus that their airway begins to bubble over with that blood. There's just nowhere else for it to go. The only way out is up. And this is someone who is having a legitimate life-threatening bleed, and it is difficult, if not next to impossible, to get a handle on, because there's not a whole lot we can do. Maintain an open airway as best we can with some suction, probably put in an OPA or an NPA, do our best to assist their breathing up to and including ventilating the patient, treat for signs and symptoms of shock, reassess, monitor vital signs, and transport. So gastroenteritis, I'm going to ask one of you guys to give me the breakdown of this word. Gastro, what's the location of our gastro system?
In your abdominal area?
Yeah, in our abdominal area. So our gastroenteritis is going to be located in our gastric system. Now let's look at that itis again.
Inflammation.
Yeah, so pretty simply put, inflammation in the gastric system. Stomach, small intestines, generally associated with some abdominopelvic pain. So some lower quadrant, very much lower quadrant pain on these patients. It can be chronic, so it can be something that the patient deals with for a long time, or it can be acute. Acute meaning this is emergent right now. Generally, if it is an acute gastroenteritis, it's going to be generally a result of an infection, and it's caused by bacteria. This is most likely in children. We can have breakdown of all those mucosal layers in the gastrointestinal tract from this gastroenteritis. But if we get right down to brass tacks, it's going to have all the same signs and symptoms: abdominal pain or cramping, nausea, vomiting, diarrhea, abdominal tenderness, fever and dehydration. Sometimes shock and actual hemorrhage, so we'll start to see some signs of a gastrointestinal bleed, but really location is all we're left with on this. The abdominopelvic area, so way down low in those abdominal quadrants, is where we're going to find our gastroenteritis. Are you guys picking up on the pattern here? Anybody? Nobody? Anybody even out there?
I'm here.
Looking a bit.
All right, next thing we're going to talk about is a hernia. hernia is protrusion of a loop of generally small bowel through a tear in the musculature of the abdominal wall. Generally, it's increased with some sort of pressure. So heavy lifting causing a weakness or opening in that muscle, and a piece of bowel goes through. In older people, we think sometimes even straining too hard to go to the bathroom can cause things like hernias to pop up. Most of the time, this is not life-threatening, generally pretty easily treated. A lot of times doesn't even require surgery. But what can happen is when that loop of bowel gets out through that muscle wall, the muscle can contract around it and it will become incarcerated or strangulated. If that happens, what's not going to happen for that little piece of bowel? It's getting squeezed, it's getting pinched. What's being closed off from it?
No perfusion.
Yeah, no perfusion, and it's probably very likely to cause some sort of backup, some sort of obstruction in that bowel. So it's also not really going to be available to do its job. Some common signs and symptoms are going to be sudden onset of abdominal pain, maybe fever and rapid pulses, but a tender mass at the point of the hernia. So that's why we're checking for pain, rigidity, and distension, because as we're palpating around, you can actually feel that bit of bowel poking out through that through the abdominal wall, and we're going to actually be able to tell with relative certainty what that is and where it came from. Well, it's an internal that decided to make itself sort of semi-external, and herein lies the issue. We could also, if this has been in place long enough, have similar signs and symptoms like with a blockage. So we're going to have some abdominal pain. We're going to have a patient who maybe feels full all the time and just doesn't want to eat, up to and including some inflammatory type things, like if the bowel has actually now become ischemic and maybe even started to break apart a little bit and leak its contents. So we'll have that parietal pain instead of that visceral pain. Maybe we'll have a combination of the two. But generally, someone who has a hernia knows pretty much when it happens. They feel that sudden sharp onset of abdominal pain right when that muscle sort of lets go and the bowel loop kind of pops out of it. And they either seek help right away or they go to their doctor and it's managed. But this turns into a bit more of an acute emergency when something changes. You know, when that loop of bowel that used to be able to be reduced pretty easily, most patients can put them back by themselves, now can't, or it has caused a significant increase into the amount of pain that they're feeling. And that's when it becomes an acute emergency, and that's when a lot of the times we'll find these people. Next, we'll talk that abdominal aortic aneurysm again. Remember, the bubbling on the outside of the wall of that artery makes it start to get a little thinner and a little weaker and a little bit thinner and a little bit weaker, and then all of a sudden, poof, it lets go. And when it lets go, your patient has a significant internal hemorrhage. This can happen to people of any age, but generally it is men over the age of 60. It is associated with a history of pretty significant, pretty uncontrolled hypertension. It may start out as sort of a slow onset of lower back, groin, or abdominal pain. It grows to become pretty severe abdominal pain that feels like a tearing pain. If we get to the patient and we feel that pulsing mass along their midline in their abdominal cavity, we don't touch that again. We really want to stay far away from that as humanly possible because we don't want to go ahead and make it start leaking or make it leak worse. This may be a patient who is in some pretty profound shock. It may be a patient who has decreased or no pedal pulses or femoral pulses at all. Why do you think the femoral or pedal pulses might be missing?
Blood flow isn't getting there.
Yeah, we're having a problem with blood flow. Blood flow is not making it there because the aorta has sprung a leak, and that leak is preventing any blood from getting to where it needs to go to perfuse those lower structures. So this is all pretty simple, right? Vomiting, diarrhea, and constipation. Well, vomiting, okay, my patient's going to be vomiting. Diarrhea, my patient's going to have, the trots. Constipation, well, that's the opposite end of the scale. My patient can't go. But let's talk about what some of the actual issues behind all of these things might be. Because what's my patient losing when they have significant vomiting, diarrhea, or constipation?
Fluid.
Fluid,
Electrolytes.
electrolytes. So this might be someone who's pretty profoundly dehydrated. Maybe when we're doing our skin color, temperature, and condition assessment, we see somebody who we could light a match on their lips. Or maybe we start to see some signs and symptoms of non-hemorrhagic hypovolemic shock, all because my patient has had nausea, vomiting, diarrhea, or even constipation, because constipation will do the same for days when we're talking adults, or maybe just hours when we're talking pediatric patients. Pediatric patients don't have the fluid reserve that we do, so they have a very, very difficult time when we talk dehydration at keeping themselves a viable human just from fluid loss. Kids can be about as sick as kids get just from dehydration. But we're going to look for the signs and symptoms of shock, because nausea, vomiting, diarrhea, all in and of itself aren't necessarily, these super crazy dangerous things until we start to see them going hand in hand with things that we know are dangerous and are scary and are pretty negative for our patient, like signs and symptoms of shock. So here we have someone who likes to ingest foreign bodies. The dark bit right here on the screen. Anybody want to take a guess at what that is?
Battery.
It is indeed a battery. And we can actually look at these pictures and watch it move its way through the GI system. And then we get to our last picture, and poof, magically it has disappeared. It has disappeared itself right into the toilet because that foreign body passed. Not all of them do. And a lot of the times, if a foreign body gets stuck and is not going to pass, your patient winds up with a blockage. So we start to see some of that stretching and start to see some of that inflammation and irritation and possible even rupture. But what we're going to be wound up with is the leaking of a hollow organ. And the leaking of that hollow organ is going to show us that parietal pain. And we're going to realize from what we just went through that parietal pain is normally inflammation, and that inflammation is normally the leaching or leaking of bacteria aggravating the tissues, and that tissue aggravation is what is causing our pain. So we have gotten to the wheres and what fors pretty much, and done the best assessment that we can just by finding all that stuff out. So we'll run through our assessment here real quick. Obviously, safety is number one. Scene safety, BSI. We treat abdominal pain like every single patient that calls for abdominal pain has a life-threatening illness. until proven otherwise. Because of all the things that can go wrong and all the blood loss that can be hidden and all the infectious materials that can leak, these are potential threats to your patient's life. We're going to start looking for mechanism of injury and try and rule out trauma, especially if we don't have real good information going in, because most of these abdominal organs are very susceptible to traumatic forces. If we know this is a straight medical call, by the time we get to our patient's side, we can treat it as such. But we also want to make sure that we're not walking into our abdominal patient thinking, it just came over as abdominal pain, no big deal, and come to find out they are in the front yard stuck on a fence because they fell off the roof and it's protruding through their abdomen. Always go in open mind and try and make sure you get all your information sorted out as quickly as you can to provide the most good for your patient. Moving into our primary assessment, we're getting our general impression of this patient. What is your general impression of this patient?
In pain?
Yeah, they're in pain. I mean, that's not the way people normally go about their day, right? People don't just decide, you know what, this spot on the rug looks great. This is where I'm going to lay down and I'm going to clutch my belly because, this all seems comfortable. This is what's called the guarded position. Look at the way her body has drawn up her legs and folded her arms across her abdomen, trying to make sure that anything and everything stays right the hell away from the spot that hurts the most. We're still going to go through our ABCs. We need to make sure that airway is open, clear, and secure. If it's not, we fix it. We're going to go through our breathing assessment, get our rate, rhythm, and quality. We want to look at our breathing and make sure that it is noiseless, effortless, and painless. We want to apply some oxygen, 15 liters per minute non-rebreather mask to this patient. We're going to check our circulatory status. We're going to get skin color, temperature, and condition, and rate, rhythm, and quality of her pulses. If you start thinking that your patient has a AAA, take their shoes off and check and see if you have pedal pulses. If you don't, we've probably found a problem. We've probably already identified some signs and symptoms of shock, and it means that this patient is critically ill. Once we get through all of that stuff, we make our priority decision. Going to transport to the closest appropriate facility with an ALS intercept en route. If our patient with an acute abdomen or anything that points us towards acute issues with their abdominal structures shows any poor general appearance, so they kind of look like crap, they're unresponsive, they're altered, has signs and symptoms of shock or severe pain, they are automatically a priority transport to the closest appropriate facility with an ALS intercept en route, because we found a problem during our primary assessment. Our primary assessment points us to the fact that there is something significantly wrong with this human and we need to get them somewhere where they need to be fixed. After we've done that, business as usual. We get our OPQ-RST, we get our sample. We do that focused physical exam. We're looking for any involuntary guarding. So when we lay our patient on the stretcher or put them in their position of comfort, that involuntary guarding is when we touch something and all of a sudden my patient's body reacts to it. So I go to palpate, I had them lay nice and still. I go and I touch something and their hand like swats at me. That's the brain saying, hey, that hurts, quit it. Voluntary guarding is the patient who's sort of contracted up and just trying to keep you away. And normally it's in anticipation of something being painful. We're going to look for tenderness, rigidity, and distension. What if we find them?
Make note of it and leave it alone.
Yeah, make note of it and leave it alone. We don't have to keep really digging at it. If it hurt the first time I touched it, is it going to get any better? And the other thing that we think of too when we do an abdominal palpation, if my patient's already telling me that it hurts, do I need to palpate it? Yes. But I am also not, drilling for oil. If my patient tells me that it hurts, I need to elicit a response because I'm also checking for what they'll call rebound tenderness, which is where I push down and maybe the pain goes away or maybe it changes a little. But then when I let go, all of a sudden it comes rocketing back and is worse. Or maybe I push down and it goes away completely, but when I let go, then it's screaming again. Um, again, we're not trying to actually cause pain, but we are trying to find a response. We are trying to get some sort of, this is what happens when I do this. Treatment, pretty simple. We're going to focus on our ABCs and we're going to put our patient in a position of comfort. Most patients with abdominal pain are going to want to have their knees flexed up towards their chest. That will actually take some of the pressure off of their abdomen. If we lay them out flat, it actually tenses some of their abdominal muscles. So most of the time, if they can, they really want to sort of curl up almost into that fetal position that we saw. Give O2 or don't give O2, depending on what's going on. We want to give them nothing but by mouth, nothing PO. They don't get to eat or drink anything. Calm and reassure, just ride it out with them because this is going to be painful. Every bump that we hit, everything that we do, every time that we move them, it's going to hurt. So think about your actions before you start really doing things to try and make this as comfortable as your patient as possible. We're going to monitor for and treat aggressively for shock, so be ahead of it. Keep the ambulance warm, keep them laying down, keep them quiet, put some O2 on them if it's necessary, and we transport. Because at the end of the day, images and most of the time surgery is going to be the actual root solution. And we reassess. We reassess everybody. From the time we finish our assessment, we go right back to primary assessment, ABC, get our vital signs again, check our interventions, work it top to bottom, start to finish, all over again, trying to see if anything's changing, if anything's getting better, if anything's getting worse, and being able to recognize and react to a problem right away, rather than, all of a sudden we go to pull our patient out of the back of the ambulance and, whoa, they're unresponsive. Get out in front of these things and start noticing the little differences. And the little differences are going to be what will actually help you do the best for your patient that you can. So next, we're moving on to the genital, urinary, and renal. Little bit of this. So genital urinary, it has to do with urology. Urology is the branch of medicine that studies the urinary system in both males and females. The female reproductive organs are separate from the urinary system. However, in males, the structures are shared. The genital urinary system is how it's referred to as males. Patients that have renal or genital urinary problems generally will experience abdominopelvic pain. So again, we're talking way, way down in that abdominal cavity, like the absolute bottoms of the left and right lower quadrants. The urinary system composed of kidneys, ureters, urinary bladder, and urethra. So here on our picture, we have the kidneys. The kidneys' job is to filter all of the byproduct and all of the just crud and waste products out of our blood. The kidneys filter all of that, blood passes through them, gets filtered by the nephrons, and turned into urine. That urine passes down through these ureters. The ureters transport that urine to the urinary bladder. Anytime you hear something is a bladder, its job is to store something. Gallbladder stores bile. Urinary bladder stores urine. And sooner rather than later, that urinary bladder becomes full enough that it needs to be emptied. Once it needs to be emptied, it passes through the urethra and is sent on its merry way into the toilet. One of the big problems anytime we have an area of the body where the inside and the outside come together at an opening is infection. Urinary tract infections can actually progress and migrate through the urethra and the urinary tract, up into the urinary bladder, up into the ureters, and actually into the kidneys. The worse they get, the higher they go. In men, it can also affect the prostate gland. UTIs are mostly caused by bacteria entering the urinary system through the urethra. Elderly patients, patients who are immobile, patients who are catheterized, some diabetics or pregnant women can also be very prone to urinary tract infections. But let's go right back to, what do we expect to find? Well, abdominal pelvic pain and tenderness. So let's draw our line. For argument's sake, we'll say the umbilicus is right there. I'm not a very good artist. Our abdominal pelvic cavity is the bottom of the abdomen and the organs of the pelvis. So our abdominal pelvic pain is going to be, just like I said, right in the absolute lower bits of our abdominal cavity. If you look at the little box that I just drew, what's the only thing that lives there?
Bladder.
Yeah, the bladder, bits and pieces of the genitourinary system. We may see some hematuria, which is blood in the urine. Our patient, when we ask about their last ins and outs, may say that the urine was kind of cloudy. That's from the bacteria being in there. They may complain of a significantly foul odor when they use the bathroom. Could be pain or burning with urination, frequent urge to urinate. Could, as it's progressing, turn into some genital or flank pain. That flank pain is sort of like the back portion of, I don't want to say the back portion of the front of their body because that doesn't make sense, but you know, the mid-axillary line that goes through our armpit and draws a straight line down our body, splitting us into anterior and posterior. Flank pain is going to be located on like the outskirts of that, sort of the retroperitoneal cavity, so sort of towards the back, but right along that mid-axillary line. And then we have signs and symptoms of infection: fever, chills, nausea, vomiting. But some of the real hallmarks of this are going to be that pain or frequent urination, but almost complete inability to move any urine when they have it. That cloudy urine or a foul, strong odor, that's going to really point us towards the genitourinary or UTI system being infected. Next, we have kidney stones. Now, I've never personally, but I have been involved with the treatment of plenty of people who have had kidney stones. And I'll tell you, boy, howdy, if I never have one of these, it'll be too soon, because the amount of pain that these things cause is just absolutely ridiculous. Kidney stones or renal calculi, they are crystals, like the electrolytes a lot of the times in our blood, calcium, uric acid, things like that start to form and actually make little almost pebbles in our kidneys. And the kidneys are okay with that for the most part. It might be a little uncomfortable. We might early on start to see some hematuria or blood in the urine. But when those kidney stones migrate from the actual kidneys themselves and start to move into these little narrow tubes is when the fun most of the time begins for our patient. When those kidney stones are on the move, our patient will complain of intractable flank or back pain that is really severe. Some significant abdominal pelvic pain or tenderness, maybe even some groin pain, depending on how close that renal calculi is to the outside. Frequent need, not urgent need to urinate, like they have to go right now because their body's really at that point working to get that renal calculi, that kidney stone out. Some of our signs and not signs and symptoms, some of our causes can be family history, a patient with a hyperparathyroid, recurrent UTIs, dehydration, obesity, just about anything that makes you particularly unhealthy can put you on the list to wind up with these fun and exciting little things. And from the times I've seen it in the field, I'll pass. Thank you. Stay well hydrated and get up and move around. And I believe last on our little bit here, we're going to talk kidney failure. So kidney failure comes in a couple of different flavors. We have acute renal failure. Acute renal failure means it is happening right now. It is not something that the patient deals with all the time. It has normally got an actual root cause to it. Something like decreased blood flow to the kidney, trauma, cardiac failure, shock, sepsis, urinary tract obstruction. So my patient now, one of those renal calculi got stuck and the patient can't actually excrete any of that waste product. The kidney is going to eventually fail. It's going to eventually not be able to do its job because it's packed with that urine that it can't get out. Acute renal failure is generally reversible. Once it's recognized, it is something that can be fixed. Chronic renal failure, on the other hand, is permanent, life-threatening, life-altering problem. Causes are too numerous to really even get into. Diabetes and high blood pressure are generally the two big ones. So uncontrolled diabetes and hypertension are just murderers to the kidneys. This is your patient who requires dialysis or a kidney transplant. Dialysis is a medical treatment where the blood is pumped through a machine and the machine actually filters out all of that really just waste that the kidneys were supposed to, and then pumps the blood back into the person and they go on about their day. It is about a 4-hour treatment 3 times a week. So every other day for about 4 hours, your patient will go and get hooked up to this machine and it will pump their blood through it. It will filter out their blood and that's it. Part of what goes along with chronic renal failure is a problem with dispensing of fluid. So a lot of our chronic renal failure patients are going to be on what they'll call water pills. So things like Lasix and things of that nature to help their kidneys, whatever function is left, still get some fluid out and still actually generate some urine. But soon enough, those kidneys just stop doing the job altogether and they actually really don't produce much in the way of urine. Really, dialysis is about the only thing keeping these folks going. If it weren't for dialysis, it would be probably somewhere between 7 and 14 days where enough of the waste product doesn't get filtered out that our patient would just pass away. Chronic renal failure, as far as complications goes, we'll see anything else along the lines of fluid problems. So we can have pulmonary edema. We could even see some cardiac tamponade. We could see some respiratory distress. We'll get some crackles sometimes. We'll start to see signs and symptoms of some congestive heart failure. So maybe even some of those distended jugular veins. It'll cause cardiac dysrhythmias because there's a problem with electrolytes and metabolic problems. So the heart really isn't beating the way that we want it to. If a patient's complaining of decreased or cessation of urination and showing some signs of fluid building up in their body, so when we palpate their feet and we can leave those divots in the tops of their feet, and maybe we hear some crackles, maybe we don't, maybe we see some hypertension and some tachycardia, we start to put things together that maybe, you know, this is a chronic problem that is now becoming acute, because they're only going to retain so much fluid before we start having respiratory compromise, cardiac compromise, and stuff starts really feeding into that negative cycle, and our patient just continues to get worse right there, right in front of us. So the last thing I'm going to show you in regards to this is, here's our patient in an actual dialysis clinic. This is where they go that 3 days a week for 4 hours at a time. And this is what it looks like. A large percentage of our call volume, believe it or not, is transporting patients to and from their dialysis appointments. Here is how the whole thing works. We have a fistula. What happens is they will go in, hopefully ahead of when this patient who has chronic renal failure goes on their treatment. They actually go in and they sew an artery and a vein in their arm together so that they are functioning sort of as the same. And then they take needles and they insert one that goes through the machine, and they have all sorts of dialyzers. Dialyzers is the actual filter itself. They have a drain to actually introduce the filtration material into the blood and then remove the filtration from the blood. And then the machine just pumps that blood right back into the patient. And from there, they just wait for their treatment to be over. These fistulas are of the utmost importance to this patient. Without that fistula, they can't receive their treatment. And if they can't receive their treatment, then they will sooner rather than later either need a pretty significant intervention to put a chest cath in, or they will just die. AV fistulas or arterial venous fistulas, we cannot take a blood pressure on the same side. So if we have a patient who's got a left-sided AV fistula, we cannot take a left-sided blood pressure. The vasculature being sort of Frankensteined together, it is got veins that aren't used to it in a particular area under some pressure, the arteries under pressure, and this whole thing is constantly being poked with some pretty large gauge needles. So these are very, very prone to bleeding. They are very difficult to stop once the bleeding begins. So our dialysis patients, people that we have, that we pick up 3 times a week to bring to these appointments, are some of the absolute sickest patients you will ever come into contact with. And really, some of them are up just walking around, living a fairly normal life, and they are chronically ill patients. The one time I have gotten enough blood on me in the field to like really need to go home and shower and change and feel pretty gross about how my morning went was from a patient who had a dialysis fistula rupture. And it was just a bloody halo on the floor around her. And to get that bleeding under control was near impossible. Thankfully, we were right around the corner from the hospital. So we boot scooted boogied and we got her there. But it was an absolute mess. and the blood that I got on me actually made my pants like wet to the touch. It was not a good morning. So keep in mind that just because you see these people all the time doesn't necessarily mean that they are in the best shape. Does anybody have any questions here for our abdominal genital urinary?
I'm sure I will, just not at the moment.
This isn't, this isn't really like the deep water that we've been covering with shock and cardiology and respiratory and all that stuff. This is fairly straightforward, and it's what do we find and what do we see that goes along with it? Because our treatment for the abdominal genital urinary stuff is most of the time very, very supportive and very much just trying to make sure that we get our patient to definitive care in as good a shape as we found them. And that's really the long and short of it. All right, next we're going to talk toxidromes, but first I'm going to give you all a bit of a break. And then after we finish toxicology, we'll get into some environmental type emergencies. Environmental emergencies are about as common sense gets, because, well, if my patient's too hot, I'm going to cool them off. And if my patient's too cold, I'm going to warm them up. Congratulations. But we'll get through toxicology and we'll see what we got left for time. But first, why don't we take 10? And when we come back, we will tackle what's next. All right, everybody, we are back and after it. We are going to talk chapter 21, toxicology. And toxicology, we really can break down into very, very simple terms, because what we're going to talk about mostly is what we call toxidromes. Regardless of a substance, regardless of really what a person chemically has put into themselves or has gotten put into them, if we just think in the broader topics of toxidromes, we'll be able to figure out just what the substance is based on what it is showing us for outward signs and symptoms. Most of our treatment for people who have some sort of toxic exposure is, again, really primary assessment driven, reassessment and just dealing with things that present themselves to us. The only reversal age we cover for any type of toxic substance is Narcan and ventilation for our overdose patient. So toxicology 101, we are going to talk a collection of signs and symptoms that result from any given poison. We will see the same things from the same types of chemicals that have gotten into our patient, and they really affect the nervous system. That is the way all of these things work. We're either going to see alteration to the sympathetic nervous system or alteration to the parasympathetic nervous system. We're going to see mostly, a lot of the times, what we call either sympathomimetics, or things that enhance the sympathetic nervous system, or we're going to see central nervous system depressants. So sympathomimetics excite the central nervous system. Think things like stimulants, caffeine, cocaine, methamphetamine. They're all stimulants. They are all going to speed things up. Anything that is a central nervous system depressant is going to begin to slow things down. So when we talk parasympathetic nervous system, the parasympathetic nervous system is that feed or breed. Parasympathetic nervous system controls saliva production, respiration, ventilation, you name it. So we're going to see some changes to our patients' respiratory status, mental status, things like that. And really what we're looking for when we talk toxidromes are vital signs, skin color, temperature, condition, and an eye and neuro exam. That is going to give us the keys of the kingdom. Sympathomimetics, stimulants, everything is up. Vital signs will include dilated pupils. Our central nervous system depressant, everything is turned off. Vital signs are going to be very, very depressed. We're going to have a slow heart rate, a slow respiratory rate. We're going to have a decreased or depressed level of consciousness in those itty bitty teeny tiny pinpoint pupils. When our parasympathetic nervous system is having that cholinergic response, everything is wet. So in the book, if you guys got to this chapter already over the weekend, you would have seen sludgeum. That's going to be our toxidrome for our cholinergic response. So salivation, which means they are just drooling uncontrollably. Lacrimation means their eyes are just leaking uncontrollably. Urination means they are just wetting themselves without even knowing it. Defecation means the other side. Our patient is just going to have absolutely no control of their body, of their bowels. And that toxidrome moves right on down, and it means their lungs are filling up with fluid, their vasculature and their third space, or the spot between like cells and tissues, is beginning to be wet and all sorts of just underwater and unable to really accomplish its task. So if our cholinergic response is everything's soaking wet, our anticholinergic response is everything is dry. So our anticholinergic person who's been exposed to something of that sort is going to be, mucous membranes are going to be like dust. We're going to see probably an increased heart rate because they don't have quite the fluid volume to move their blood around. So we're going to see a different, just the absolute opposite of someone who has been exposed to a cholinergic problem. Really, our toxicology can absolutely be concentrated in these exact things. Is my patient really flying and sped up and everything's excited and everything's turned on and the sympathetic nervous system is just raging out of control? Or is that sympathetic nervous system shut down? Or my parasympathetic, is my patient just soaked to the bone or dry to the bone? Really are the things that we're looking for. The parasympathetic nervous system having issues really isn't as much as something we see a lot of the times. These are things like nerve agents or accidental poisonings from, we'll see it sometimes in like farming communities. People are accidentally poisoned by some of the things that they spray on crops will actually trigger these parasympathetic problems. But really what we see most of, and you'll see why I'm saying this in just a second, are these sympathetic nervous system problems. Because what do we know about this one right here on the screen? You guys tell me something.
It's a drug?
It is a drug. What type of response does this drug in particular elicit inside the body? What do you know about people who overdose on heroin as far as their mental status?
They're very drowsy.
Okay.
Very drowsy. All right. What about their respiratory rate, rhythm, and quality?
Slow.
Slow. What about their heart rate?
Slow.
What about their blood pressure?
Low.
What about their pupil size?
Dialing in.
Malachi, no, it's the opposite. People that are overdosed on heroin have the tiny, teeny pinpoint pupils. So this is a stimulant or a depressant.
Depressant.
Yeah, so it's a sympatholytic. It turns off the sympathetic nervous system. So we expect to see all of those things slowed down, not sped up. Heroin's an opioid drug. It is made from a flower. It is synthesized into morphine inside our body. It is extracted from the seed of the Asian opium poppy plant. It can be a white powder. It can be a black tarry substance. But let's take a look at some of the percentages here, because this is always something that I thought was just nuts. In 2015, so 6 years ago, 828,000 people in the United States aged 12 or older had used heroin once at least in the past year. So 0.3 out of every 100 people over the age of 12. I don't know about the rest of you guys. I'm not sure of everyone's ages, but there's nobody that's, 18 years old, I don't think, and fresh out of high school. I hadn't had my first beer at 12, let alone my first taste of heroin. I just don't even understand that number. 12 years old is just like a baby to me when I think about it now. In 2014, more than 11,000 hospitalizations had occurred from heroin-related poisonings, so overdoses. 11,000 people in just the US alone. And it's only gotten worse. Between 2014 and 2016, it says it increased fivefold each year. So that means that 11,000 in the 2 years between 2014 and 2016 has gone up to somewhere probably around 100,000 or more. Death rates increased by 20%. Almost 15,000 people died in 2016 from heroin overdose. I don't understand. I don't see what the draw is to these types of substances, but that's not for me to figure out. All I need to know is how people use them and what I can do about it. So heroin can be injected, snorted, or smoked. Any of our opiates can be used in these exact same ways. So it doesn't have to be heroin. It can be OxyContin. It can be hydrocodone, oxycodone, so our Vicodin or Percocet. It can be fentanyl, it can be Dilaudid, it can be carfentanil, which we'll touch on briefly here in a minute. One of the good things about heroin being a naturally derived product is that Narcan works on it very, very well. When we talk fentanyl and carfentanil and things like that, it takes generally a lot more Narcan and a lot longer of a time for that Narcan to get in and knock the opiate off of that receptor and actually start to reverse the overdose. So these are our patients that we see that we give them a bunch of Narcan, and if they wake up at all, they very much still remain pretty well drugged and pretty well messed up. It binds to our opiate receptors, and that is what the Narcan's actually trying to do. It is trying to go in and really physically remove all of that heroin from those opiate receptors and make it so that now my patient's not only breathing 4 times a minute and not really having a problem with their mental status or their respiratory status or any of the other problems we see from our opiate overdose. But opiate overdose isn't the only problem we have when we talk people who use narcotics or opiates. Because opiates, your body will build up a tolerance to. And as that tolerance increases, the amount that needs to be used will increase. The way that the patient actually has to use the drug will increase. Because when we see people who start using these substances, they don't generally start out as IV drug users. For the most part, people will start by using opiates themselves. They'll, on the weekend, they'll buy a couple of Percocets and have themselves a party, whoop-de-doo. And then the body develops its need. And once the body develops that need, the amount of drug that they're going to have to take into their person goes up. And if the amount of a substance that someone needs to use goes up, the price tag goes up. So they switch from now just buying a couple of Percocet on the weekend to now they are actually buying heroin and using on a daily basis. So it starts to become more expensive even to just use heroin, because most people start out as either snorting or smoking, because the idea of sticking a needle in yourself really kind of turns people off to that. And then they don't get the same high, and they're constantly chasing that high. And in constantly chasing that high, their body is building up a bigger tolerance and a bigger dependence. So sooner rather than later, the smoked and snorted effects of heroin begin to wear off. And that's most of the time the progression that's followed when people switch to now IV use of this drug. And then they can get more bang for their buck. They have to buy less heroin because they have to use less heroin, because now they're shooting it directly into their bloodstream and the effects are immediate. But then we wind up with all of these other downstream problems. We can have infection of the heart valves. We can have collapse of veins. We can have veins that just are complete rubbish when people like paramedics show up and try and start an IV. It'd be like trying to push a needle through this table, because there's been so much repeated damage to some of that vasculature. We have infectious diseases from things like hepatitis. Needles get reused, needles get shared, because, and it shouldn't even really be that way anymore, because you can, as a user, go and get clean needles. You can exchange dirty for clean, 1 for 1, no problem. But sometimes that's, the drive for a lot of these users is just the drug. I need to get the drug. I need to get the drug in me. So going down to the pharmacy and picking up fresh needles isn't exactly tops on the list of things to do. So we see some communicable diseases, things like HIV, AIDS, hepatitis B, hepatitis C, and it just causes another layer of problem for our drug addicts. The addiction portion of the patient's brain is just impossible to understand, sort of in just a short amount of time we're going to go over this. But their body does become physically dependent on this. This is a chemical dependency. Addicts who have had to quit cold turkey, they have some of the worst muscle and bone aches, uncontrolled vomiting and diarrhea. This slide actually says can eventually cause death. Withdrawal from the drug is not actually what is causing this patient to die. But if what we just talked about with nausea and vomiting and diarrhea, and then failure to keep up your fluid level, you can still wind up every bit as dehydrated and every bit as much in shock and every bit as dead from the clearing out of your system from this drug as anything else. It is not really the actual dependency and the lack of the drug that is making you die like with alcohol. It is more the side effects of the body sort of ridding itself of the toxin. We can see some lung problems, some pretty significant persistent pneumonia, and then the lack of aseptic technique at the injection site will start to have some abscesses and infection in the skin. We can fix most, if not all of this with a patient when we find them in a drug overdose by our typical management. ABC, we're going to maintain an open airway. We're going to assist their ventilations, because remember, all their central nervous system turned pretty much off. So we maintain an open airway and we ventilate for 3 to 5 minutes. We're trying to reverse some of the effects of that hypoxia. We're trying to reverse some of the effects of that hypoperfusion. And in doing that, we're actually going to ease their transition when we wake them up. We're going to make them maybe not quite as altered and confused and possibly even violent. We want to monitor their heart rate to make sure that they are still not in cardiac arrest from this overdose. We can give 2 to 4 milligrams of Narcan intranasally. It's just going to depend what's stacked on your truck. We're still using up some of the old 2 milligram doses, but most trucks now have that 4 milligram single use injector that we've been showing you here in class. After that first dose, we're going to ventilate for 5 more minutes. And if they need a repeated dose, if they have to have a second one, we give them that second dose and we just continue to ventilate, because the hypoxia and the hypoperfusion is really what is going to be the crux of what kills this patient. So we need to fix that problem. And in fixing that problem, we can have a much better outcome for this patient. But too much Narcan is not advisable. Moving on, we have fentanyl. Fentanyl has gotten a whole lot more airplay lately because people are mixing it in with heroin, people are mixing it in with other drugs. And really, at the end of the day, we're just talking about another opiate. This opiate happens to be synthetic. So let's have a quick look at the next 2 bullet points. Fentanyl is 30 to 50 times more potent than heroin. That means you are going to get 30 to 50 times more jammed off of the same amount of heroin. It is 50 to 100 times more potent than morphine. So it takes much less fentanyl to have the same action and have the same reaction inside the body. That's why it takes more Narcan. It takes more time when we have someone who is overdosed on fentanyl to actually start waking up and start coming back around into the realm of breathing on their own, maintaining their own airway. Our neuroscience and symptoms: decreased responsiveness, pinpoint pupils, everything that points us towards central nervous system depressant. But look at what's changed. Nothing's changed. ABCs: maintain an open airway, ventilate, oxygenate, monitor their heart rate, and give Narcan when indicated, period. So now the picture that you're going to see next is going to be why when carfentanil first came around and everybody was talking about how dangerous it was, you'll see exactly why. So fentanyl, 30 to 50 times more potent than heroin. Now, these needles are a pretty well adequate picture representation of the difference in strength. Look at that carfentanil needle compared to a fentanyl needle, and you'll see that carfentanil is a synthetic drug much similar to fentanyl, but it is the most highly potent opiate in the world. It is 100 times more potent and more powerful than fentanyl. So that means it's somewhere between 3,000 and 5,000 more times more potent than just your average everyday run-of-the-mill street heroin. It was initially used as a tranquilizer for the big 5 animals in Africa. So water buffalo, elephants, lions, hippopotamus, and rhinoceros. How this ever was something that got put into people, I have absolutely no idea. But for the most part, if this hits the streets around, all the Narcan in the county is not going to be enough to really affect that much of a difference, because a tiny dose equal to about the size of a few grains, not even grams, a few grains of table salt will prove to be lethal. And the way that the whole drug trade works and the way that the whole sort of use and abuse of these opiates works is the drug dealer who has the best stuff gets the most patients, gets the most customers. So sometimes a purer, less cut product will be put out by a drug dealer. It'll cost him some money to not cut the product down quite as much and not make it a little more diluted. But what'll happen is on the street, word will get around that they have the best stuff. You get the highest, 12 people have overdosed from stuff that he sold them. And then there's a line around the corner, like going out of style, like you were trying to buy tickets for your favorite concert, waiting in line. Or, the new Star Wars movie came out and people are camped out in front of the movie theater. So when we have areas where we see a lot of overdoses in a small period of time, generally we know that something like that has gone on, and it's only a matter of time before we have even more overdoses than we already see going on. But the signs and symptoms and management are much the same. Pinpoint pupils, lethargy, sedation, shallow breathing, loss of consciousness, cool, clammy skin. The more potent the opiate, the more likely our patient is to show some pretty significant outward signs and symptoms of shock, possibly even be in cardiac arrest. But our treatment doesn't change. We're going to monitor and treat our ABCs appropriately. We're going to maintain an open airway. We are going to ventilate the patient for 3 to 5 minutes before we even reach for any Narcan. We're going to monitor their heart rate. Then we're going to give our Narcan if it's still indicated. Then we're going to ventilate again. If they wake up after the first dose, fantastic. We ventilate a little bit more. We fix that hypoxia, like is what we're looking to do. And from there, we transport, reassess, and treat as things arise. So that's our central nervous system depressant. Now we're going to have a case study. We're dispatched to a 28-year-old male presents in police custody complaining of chest pain. He has no prior history of cardiac disease. Was arrested at a local international airport for combative behavior while standing in line near the security area. So, what do we know about chest pain and cardiac disease?
Usually wouldn't be somebody that young.
Yeah, 28's weird, right? So general impression is already sounding kind of wonky. And our typical patient with cardiac disease and chest pain, do we expect combative behavior?
No.
No, most of the time they feel too crappy to be of any danger to anybody but themselves. So chief complaint and general impression and things that we're thinking of generally right here don't kind of go off into the sunset together, right? If this guy had been 70 and sitting in a chair and just looked gray and terrible, well, our general impression and our chief complaint, and we'd be kind of on the right track. But let's take a quick peek here at our case study physical exam. So the patient appears very agitated, clutching his chest. We have a heart rate of 140, a blood pressure of 220/130, a respiratory rate of 28, and he has a temperature of 103.2. He has pupils that are 7 millimeters in size. Now, if you think about the little dots that are on the side of the pen light that I hand out to you guys, 7 millimeters is big. There's 10 millimeters in a centimeter. So it's almost a full centimeter in size. That's most of his eye. Lungs are clear to auscultation. Anything jump out of this here just yet?
His blood pressure.
His blood pressure is high, his pulse is high, his respiratory rate is high. Why is his temperature up, you think?
Because his heart's pumping so fast and everything else is moving so fast that it's just generating heat.
All right, so now, as we're thinking in our bag of tricks, what do we think's going on with this person? We're talking toxidrome, so we know it's some sort of toxic ingestion. What type of toxic ingestion could this be?
Opiate?
If it was an opiate, opiates being a central
Oh,
nervous
yeah.
depressant,
Right.
we'd be on the other side, right? He'd have a pulse of 40. His blood pressure would be like 70 over palp. His respiratory rate would probably be somewhere around 6. And he'd be chilled because of that lack of perfusion. Now, like you said, his heart rate's up, his blood pressure's up, his respiratory rate's up. All of that is generating a lot of internal body heat. So does this sound depressed or stimulated?
Stimulated.
Moving right along, we have a distended abdomen with diffuse tenderness, hyperactive bowel sounds. So those are moving fast. That's all excited and turned up too. We have strong pulses, no cyanosis, no track marks. His neuro eval is clear, and he is sweating like crazy, diaphoretic. We're starting to really connect all the dots here. This is our patient's cardiac rhythm strip and 12-lead ECG. That's not really going to be significant to us right now. But you hit the nail right on the head. He is on a stimulant, and I believe there's some pictures coming up, and I can show you exactly what's going on with that guy. Any type of stimulant. It doesn't matter if it's cocaine, methamphetamine, you name it, anything that people can use to cause themselves to be stimulated and cranked up is going to cause those same exact symptoms. Elevation in their heart rate, elevation in their respiratory rate, elevation in their blood pressure, possibly depending on how much of the substance they've been using, their body, by doing the things that their body is supposed to do, could actually generate enough heat to stimulate them to have a temperature. Pupils will be very, very big and dilated. These drugs can be snorted, injected, smoked, can be rubbed on mucous membranes, and what it's doing is preventing the reabsorption of dopamine. It is pretty immediate as far as the high generated from these drugs as well, but they do not last very long, which makes people use more and more and more and more and more, and just continue to crank up all of those stimulated central nervous system sympathomimetics and just have those raging, crazy, out of control vital signs. Here is an X-ray of our patient. So if you look at this picture, every little blip on this screen here is a packet of drugs. And what happened in that case study was at least one of the packets opened. And however much cocaine happened to be in that pouch just got digested and wound up directly in our patient's bloodstream. And in doing so, he was agitated, he was combative, he was tachycardic, he was hypertensive, he was he had a rapid respiratory rate, and he showed us all of the absolute factual typical signs of somebody who is on a central nervous system stimulant.
Because that said it was an international airport, right?
Yep.
That makes sense.
So we've gone through the toxidromes. All right. Last but not least on our trip today, we are going to talk environmental emergencies. Since it is freezing cold and windy out, we are going to talk first and foremost exposure to the cold. So we are talking generalized hypothermia right now. Hypothermia means low body temperature. Go figure. Hypo is low, thermia going to be our temperature of the blood. Hypothermia is going to be increased heat loss. So we are losing body heat to the environment around us, or just a decrease in the body's heat production, or both. Mortality from generalized hypothermia can be up to 87%. Hypothermia is sort of a silent killer. It really does all sorts of weird things chemically and physiologically inside the body. It can have a sudden or gradual onset. So, think of falling through the ice. Well, very rapid onset of heat loss and decreased heat production. So we're going to have a sudden onset. But then think of just spending too long outside in an environment that puts you at an exposure to wind and wet and cold air, and how much that sort of just sucks that body heat right away from you. You aren't necessarily always having a real significant initial loss to the amount of heat production, because you'll shiver and you'll generate some heat. But the longer you're in that environment and the more prolonged the exposure is, the worse you're going to wind up doing. We do find some things that will be listed as predisposing condition, well, not conditions, factors. There are some predisposing conditions. We'll talk about some medical conditions that make people a little bit less likely to do well when exposed to the cold. But ambient temperature, wind chill, and moisture. You are much more susceptible to hypothermia on a cold day that is windy and wet than you are on a cold day that is just windy and cold. That wet adds another very significant layer to all of this when we talk about the ways that heat is actually lost from the body. People at the extremes of age, so the very, very young and the very, very old, are also going to have a difficult time overcoming some of these heat loss versus heat gain emergencies, because they don't really just have the ability of their body to fight these things off. They don't have the same subcutaneous makeup that we do that keeps us insulated and keeps us warm. They don't have the same fluid volumes like we do that can sort of overcome some of these issues. When we talk different medical conditions, so people with cardiovascular problems, people with diabetes, people that already have some problems with perfusion are going to have some issue with being exposed to the cold. Generally, the healthier someone is, the better their body will adapt to and get better from hypothermia. Alcohol and drugs are two things that generally are considered very, very bad for someone who's been out or exposed to the cold. The barriers and clothing that you're wearing can give you sort of a leg up in your body's ability to fight off the cold. And activity level. If you're going to be out in cold weather for an extended period of time, you don't ever want to sweat, because sweat is actually moisture, and that moisture will eventually hit that cold and will start to sap more and more heat away from your body. There's 5 stages to hypothermia. The last one's death. First stage is the body is shivering. Body is your normal response to being too cold. Your body is using friction of the cells shivering and the muscles constantly contracting to actually physically generate heat. But once the body temperature has gotten below 90 degrees Fahrenheit, shivering no longer is effective. After that, we'll reach stage 2, where you lose control of your muscle functions. Now, it starts out as like fine motor control. One of the things that I've seen in some like wilderness type stuff that I've looked at is your ability to touch your thumb and pinky together. The minute that you can't make that happen with the fine motor control in your hand, you've been out in the cold for too long and it's time to go inside and get warmed up. as you get colder and as things progress, that fine motor control is completely gone. And then you start to lose the ability to have gross motor functions. So walk and move and pick things up and now extricate yourself from this problem. That apathy means you kind of mentally lose the thought of caring anymore about being cold. From there, you progress into stage 3, where you actually will start to have a decrease in level of consciousness and level of responsiveness. You start to have sort of like that glassy-eyed stare. The extremities may actually physically become frozen and solid-like. From there, you enter into stage 4. Stage 4 is when things begin to slow and shut down. You will have a decrease in vital signs. You will have a decrease in blood pressure, pulse, respiratory rate. And part of that is good, because if my heart rate goes down, my blood pressure goes down, and my body's beginning to sort of turn itself off, what's it requiring less of?
Oxygen.
Yeah, it's requiring less oxygen. Take a look back all the way to step 2. We have fine motor control slowing down and stopping, gross motor control turning down and stopping, the brain sort of slowing itself down, the vital signs starting to slow itself down. We're requiring less energy. We need less metabolism to take place. And it's sort of a self-preservation method. The general saying in a person who is hypothermic is they aren't dead until they're warm and dead, because the human body can actually slow itself down to the point where you can reach just ridiculous body temperatures as far as core internal temperature goes, and still survive just because of the decreased level need for metabolism and need for oxygenated blood flow. And obviously, when we get to stage 5, we find death. Now, these hypothermic patients, these are the ones that I mentioned we may need to count, like respirations and ventilations, for a full honest to God minute, because they may have turned down their bodily functions so much that it's hard to count their respirations because they're so slow. And it's hard to count their heart rate because they're so slow. And it's hard to count their heart rate because their blood pressure is now so low that it's difficult to even find these peripheral pulses. Plus, their extremities could be frozen. Some of the real important things to remember of someone who's in this kind of hypothermic state is to handle them very gently. Frozen tissues don't do real well when they're handled roughly. We want to make sure we're not causing any physical damage. Not to mention their heart gets kind of cranky and is very susceptible to be thrown into non-survivable, non-perfusing rhythms like ventricular fibrillation by something as very like innocuous as just a little bump. So take a nice easy ride to the hospital. They're not getting any colder if they're in the back of your ambulance. So, be careful when you move them, be careful when you transport them, because we can't afford for them to get any sicker, which the minute you get them out of the cold and get their cold and wet clothing off and get them started to acclimate to the warm temperature in the back of the ambulance, they're already starting to get better. Obviously, if we're going to be immersed in water, we want it to be for as short a time as possible. Your body temperature drops approximately 30 times faster in water than it does just in the average air. We can actually become hypothermic in water that is anything below 98.6 degrees. It is entirely possible to freeze to the point of death in 50-degree water. So So just because somebody hasn't been in, ice cold water doesn't mean that they aren't profoundly ill. Obviously, our priorities for treatment for this patient would be to get them out of that water as fast as possible, get them out of their wet clothing. That's going to be your most bang for your buck. Get the wet clothes off, because that's just pulling more heat, pulling more actual body heat away from them being in those wet clothes, and we get them into a warm environment. The same can go for what is called urban hypothermia. This is your patients who are homeless in places like New England during the winter. We want to make sure that we are removing them from the cold environment. That is going to be our first line treatment. Get them out of the cold environment. Make sure if they're wet, we got those clothes off right away. If there's any possibility that they are going to get cold again, so let's say we were working on them in abandoned building. So we're talking our urban hypothermia patient here, and we start warming them up. But then we have to bring them outside on a cold, wet, snowy day, or we have to bring them on a prolonged extrication out of like the woods or something. Leave them cold, because warming them up and then letting them get cold again just puts the body through all of the same processes and really makes that their metabolic demand gets weird. Their increased in heat loss just kind of works off of itself, and it really just puts the body through that much more stress. So if they're cold and they're going to get cold again, leave them cold. When we're going to transport these patients, we definitely want to get their clothing off, whether they're too cold or too hot. We want to get the clothing that they have on off, because all of that clothing can actually trap the cold air. In the trucks, we have those space blankets. We have all sorts of outer layers that we can put over this patient. So if we wrap them up like a baked potato in that space blanket, they're actually going to be reflecting their body heat. They're going to be warming themselves. Then we add the next layer of blanket material and wrap them up nice and tight, swaddle them like a baby. And by the time we get them into the back and get the heat on in the back of the truck, we've actually really done some very, very decent things, some very good things for our hypothermia patient. That's our generalized hypothermia. Now we're going to talk a local cold injury. So we have frostbite, right? When a piece of body tissue actually becomes frozen in appearance. Generally, it's much, much colder temperatures required to freeze an extremity than to cause that generalized hypothermia we talked about. We are going to treat generalized hypothermia first. So if we have a patient whose entire body is cold, but one particular thing is frozen, we want to make sure we take care of the whole organism first. We take care of the whole patient, not concentrate on that localized freezing injury. Local cold injury starts when ice crystals actually form between the cells, and they make those cells in that tissue actually expand, which will damage the tissue and decrease circulation. So we're going to have a perfusion problem. Generally, we see exposed areas, things like the hands and feet. Feet can get wet and really wind up pretty hypothermic. The hands, the ears, the nose, the cheeks, they're commonly more exposed to the cold. And we'll start to see some frostbite, some frost nip, and it really becomes almost to the point of just skin that doesn't look like skin anymore. It starts to get this waxy kind of shiny appearance to it. It may actually be hard to the touch. It'll start to change color, like these toes here. They may even look completely black and just no longer even look like hands and feet. a scene size up is going to be awfully important for a hypothermia patient, because if it's too cold for them, who else is it too cold for?
Us.
Yeah, me. I don't want to be out there in the cold with them. I'm looking at these frozen black, kind of crispy, crunchy, gross looking fingers and stuff. No, if it's too cold for you, it's too cold for me too. So let's get inside somewhere nice and warm. Remove the patient from the cold environment, removes you from that same safety hazard. Moving right along, we've completed our scene size up. We've gotten ourselves and our patient out of that cold environment. We're going to go right through our same primary assessment. We're going to form our general impression. How does this patient look as I approach? How are they presenting to me? That's my general impression. We're going to assess airway, especially if our patient's unresponsive. We're going to treat airway because they can't do it on their own. We're going to administer oxygen. We're going to get our respiratory rate, rhythm, and quality. We're going to check carotid and radial pulses, especially if they're unresponsive, because depending on how cold is going to depend on whether they even have palpable radial pulses. Skin color, temperature, and condition. What do you think we'll probably find here?
Pale, cold.
Yeah, they're going to be pale, they're going to be cold, they might actually be like really kind of just not skin that doesn't look human anymore, because it is frozen, or it doesn't feel human anymore. It feels more like the desk that I'm knocking on right now, because that tissue is actually physically frozen solid. We're like 75 or 80% water. So introduce that water to cold enough for long enough, and those are the problems we can expect. Our secondary assessment, what we're trying to figure out with our secondary assessment is, first and foremost, we're going to document any history that they give us. We're going to start asking them about any pain or any other associated symptoms. We'll start looking for signs and symptoms. We want to note, of course, altered mental status or any decrease in motor function, any changes to their vital signs, any changes to their skin color, temperature, and condition. But let's get right down to what we're going to do for our generalized hypothermia patient. Say it before, and I will say it again. We're going to remove them from further heat loss. We want to handle this patient gently. We want to administer O2, so we're supporting their ABCs. If the patient is found to be in cardiac arrest, use your AED. They used to say that that wasn't allowed, wasn't advisable, but now we are going to defibrillate patients who are hypothermic and in cardiac arrest. If we get a shock advised, we give a shock, period. What do you think what do you think it means to actively rewarm a patient?
Rubbing their extremities.
Yeah, we want to do things that physically make them warmer. We're not going to have them eat or drink anything, but we want to actively rewarm them, not always necessarily with rubbing their extremities, because if it's frozen, we are worried about tissue damage. So what we're really looking to do is apply heat to them in some way, shape, or form when we talk about active rewarming. So we can give them heat packs. We can put them, in their armpits and in their groins and places where blood flow is very close to the surface, in an effort to try and start to reverse some of that hypothermia. If my
Would that
patient,
be,
what's up?
I'm sorry, would that be like the warm immersion baths? Or, I mean, that's nothing that we'd have on the trucks, but would that fall into the same line?
Yep. Yeah, really a lot of what we're going to do, because sometimes those heat packs aren't even available, but a lot of really what we're going to do is concentrate on stopping the chilling. So we concentrate on removing them from the cold, getting them into the warm, and letting that do its job. Wrapping them up like a baked potato, that's going to be part of active rewarming. The reason we say don't apply heat to someone who's unresponsive or minimally responsive is because that person can't tell me when my efforts are actually causing them damage, causing them harm. They can't tell me when they're being burned. Someone who can tell me, hey, this heat pack's getting really, really hot. Oh, okay, well, I can just go ahead and remove that heat pack and that patient doesn't have a complaint in the world again. Most people, we really are just going to remove them from the cold, get all that cold, wet clothing off, and start warming them back up from the outside in. When we get to the emergency room, they'll warm them from the inside out. We're just worried about getting it started and really just stopping the cold. We already covered that. Now let's get into frostbites. So our signs and symptoms, we already went over. Blanching of the skin, lost feeling, loss of sensation. Tissue may still be soft on the very, very outside, but underneath it starts to be crispity, crunchity, peanut buttery. It's really kind of gross. Then eventually the worse it gets, now the skin gets white. It is really firm and frozen feeling when we palpate it. We may see some blisters. If there's any possibility, again, that this patient is going to become cold again, we do not want to warm them up. But our treatment really is going to remain much the same. We want to get them out of the cold, maintain airway breathing circulation, and we want to make sure that we carefully rewarm this patient and don't cause any further damage. So we go ahead and I can't think of another way to say this other than really like it really does look like they're a baked potato by the time that we're finished. We put that space blanket on them so that they're reflecting some body heat. We wrap them up in enough blankets so that we are keeping in and increasing all that body heat. And from there, we really just turn up and crank the heat in the back of the ambulance, especially for my responsive patient that can tell me when they're becoming uncomfortable. And we carry right on about business as usual, monitoring their ABCs and making sure that they maintain all of those things because that's what's keeping them alive. And we just reassess mental status, airway, breathing, circulation, vital signs every 5 minutes because it is entirely possible that this patient will turn the corner and wind up not doing quite as well as you had thought and or hoped that they would, because there is going to be some tissue hypoxia. There is going to be some buildup of some of those cellular metabolism byproducts that we talk about. It's just going to be less. So we need to make sure that we are keeping an eye out for all of that so that in the event that something pops up, we are ready and able to respond to it and correct the problem. So if our treatment for somebody who has had a cold-related emergency was to remove them from the cold and heat those nice folks up, somebody please do tell me if my patient has been exposed to too much heat. What am I going to do for them?
Get them out of the heat.
Get them out of the heat and cool them down. Now, our patient who's been exposed to too much heat, we do not wish to have them shiver because that's going to just generate more heat. We want to cool these folks down a little bit more slowly, a little bit less aggressively, but our treatment's really going to result in the exact same thing. We are going to remove them from the heat. We are going to do our level best to make sure that we don't have to re-expose them to the heat. And we're going to monitor and support their ABCs. Now, there are some heat-related differences. There are some heat-related injuries, and we'll talk heat cramps, heat exhaustion, heat stroke, and all that when you guys get here. And I believe that's part of the skill drill that we're going to go over a little bit later on. But really, all of this stuff can be boiled down much to the point of common sense. And I think, without getting too much further, I think that's where we should stop right now. We'll talk heat cramps. Yeah, we'll talk heat cramps and